Welcome, class. Today we will be focusing on foundations and trends in geriatric nursing. As we examine the latest resources and clinical best practices, remember that these standards are the cornerstone of patient safety and care quality. By mastering these foundations, you will be better equipped to reduce clinical risks and enhance the overall well-being of the older adults in your care. Let's explore how these evolving trends shape the future of our practice. The primary focus here is the paradigm shift occurring in modern healthcare, the realization that geriatric nursing is no longer a specialty subset, but the core of our clinical practice. As we move into week 1, we must ask ourselves, why is the older adult population growing at such an unprecedented rate, and how does that change our foundational nursing interventions? Looking at the interaction in this clinical setting, we see the hallmark of geriatric excellence: relationship-based care. Notice the nurse's engagement and the patient's active participation. In geriatrics, our priority isn't merely treating a diagnosis, it is assessing and maintaining the patient's functional status. We must constantly evaluate, how does this illness impact their ability to live independently? Physiologically, we have to differentiate between normal aging changes, such as decreased cardiac output or slowed gastric motility, and pathological disease processes. For the NCLEX and your clinical rotations, you must remember that while physical slowing is expected, acute confusion is never a normal sign of aging. It is a clinical red flag for underlying issues, such as UTIs, dehydration, or adverse drug reactions. Psychosocially, we are supporting the developmental stage of integrity versus despair. When we engage with patients in a meaningful way, as seen here, we are facilitating life review. This is a powerful nursing intervention that helps the older adult find meaning in their experiences, which directly correlates to better health outcomes and adherence to treatment plans. Clinical Pearl. To ensure patient safety and health literacy, always utilize the teach-back method. Do not ask, "Do you understand?" Instead, say, "To make sure I explain this clearly, can you tell me in your own words how you will take this medication at home?" If they cannot explain it, they are at a high risk for a medication error or readmission. Looking at this exponential curve, we are witnessing a fundamental shift in the healthcare landscape, often referred to as the silver tsunami. This upward trajectory of the population aged 65 and older isn't just a demographic statistic, it is a call to action for every clinician in the field. The center of gravity is shifting because our patients are living longer, but they are also living with higher levels of complexity. Increased longevity is a triumph of modern medicine and preventive care, yet we must ask ourselves, why does this change our nursing intervention? It's because the older adult today is often managing 3, 4, or 5 chronic conditions simultaneously. This is the new normal of aging. We are no longer just treating an acute infection. We are managing that infection within the context of decreased physiological reserve and polypharmacy. As the fastest-growing demographic in the nation, older adults require a specialized approach that moves beyond the traditional medical model. On the NCLEX and in clinical practice, you must remember that chronological age is not a reliable indicator of health status. You will see 85-year-olds who are functionally independent and 65-year-olds who are frail and bedbound. This is why the new mandate for care emphasizes functional assessment over a simple diagnosis. When you see this growth, you should immediately think about the increased risk for geriatric syndromes, falls, delirium, and pressure injuries. Our skills are more critical now because the atypical presentation of illness is the standard in this population. For instance, why might an older adult with a burgeoning pneumonia present without a fever, but with sudden onset confusion instead? It is due to the blunted immune response and changes in the blood-brain barrier. Clinical Pearl. Always prioritize the assessment of functional status. If a patient's ability to perform their daily routine suddenly changes, it is often the first clinical indicator of an underlying acute illness, even before vital signs shift. The primary focus here is the dual demand of the geriatric specialty, the marriage of high-touch therapeutic presence with high-tech clinical monitoring. In geriatric nursing, we are not simply treating a disease process. We are managing the intersection of multiple chronic conditions, or multimorbidity, within a body that has a significantly decreased physiological reserve. Why is the nurse's touch in the left image just as critical as the monitor in the right? Because in the older adult, psychosocial well-being is intrinsically linked to physical outcomes. When an older patient faces profound psychosocial changes, such as the loss of a spouse or the transition from independent living, the resulting cortisol spikes and depression can physically delay wound healing and exacerbate cardiac instability. Looking at the clinical complexity shown here, we must consider pharmacokinetics. As the body ages, we see a decrease in total body water and an increase in adipose tissue. This means water-soluble drugs become more concentrated, and fat-soluble drugs linger far longer in the system. How does this change our nursing intervention? It means we must monitor for toxicity, even when dosages are within the normal range for a younger adult. On the NCLEX and in clinical practice, you must anticipate the atypical presentation. An older adult with a UTI may not present with a fever or dysuria. Instead, they may present with sudden onset confusion or a fall. We must use our sharpest clinical skills to look past the obvious and identify the underlying physiological stressor. Clinical Pearl. When educating the older adult, always use the teach-back method. Given the high prevalence of sensory deficits, such as presbycusis and diminished visual acuity, never assume your instructions were heard or understood. Ask the patient to explain the why of their new medication back to you to ensure patient safety and adherence. Looking at the landscape of geriatric care, we must recognize that our practice is never just about a single diagnosis. It is about the complex intersection of biological aging, psychosocial transitions, and the healthcare system itself. To provide great care, we must move beyond the medical model of fixing a problem and embrace a holistic view of the older adult within their specific environment. Why is understanding this landscape so critical? In geriatric nursing, we often encounter the cascade of fragility, where one small physiological shift, such as a mild urinary tract infection, can trigger a domino effect, leading to delirium, a fall, and a permanent loss of independence. By exploring these trends through the story of one patient, we can better visualize how chronic conditions, polypharmacy, and social determinants of health intertwine. Ask yourself, is this patient's confusion a symptom of disease, or is it a result of the landscape of their environment? For your clinical practice and NCLEX preparation, remember that assessment is the cornerstone of the nursing process. In the older adult, this assessment must include not only physical symptoms, but also functional status and cognitive baseline. We are not just treating a disease, we are managing the trajectory of a person's life. Clinical Pearl. Always prioritize functional status. A patient's ability to perform activities of daily living is often a more accurate predictor of mortality and hospital readmission than their actual medical diagnosis. If you don't know the patient's baseline, you cannot identify the deviation. The primary focus here is the clinical presentation of Eleanor, an 80-year-old who represents the delicate balance between high-functioning independence and the sudden vulnerability brought on by the aging process. When we look at Eleanor, we aren't just looking at a retired teacher. We are looking at a patient who is at a critical transition point in her functional status. Why is a single fall in an independent adult like Eleanor considered such a significant clinical marker? In geriatric nursing, we view a fall as a sentinel event. At age 80, physiological changes such as decreased proprioception, reduced muscle mass, and slower reaction times converge to increase injury risk. However, we must also look at the psychosocial why. Eleanor lives alone and is widowed. Grief and social isolation can lead to decreased nutritional intake or distracted mobility, both of which are hidden contributors to falls. From an NCLEX perspective, your priority is to distinguish between normal age-related changes and pathological manifestations. For Eleanor, her recent fall is the priority assessment. Was it caused by orthostatic hypotension? Is it a side effect of a new medication? Polypharmacy is a constant threat. Or perhaps a sign of a brewing urinary tract infection, which often presents as a change in gait or balance before a fever ever appears. We must also consider the fear of falling syndrome. Once an older adult falls, they often restrict their activity to avoid another occurrence. This leads to further muscle deconditioning and, ironically, an even higher risk of subsequent falls. This is the cycle we, as nurses, are charged with breaking. Clinical Pearl. When a patient like Eleanor reports a fall, always perform a medication reconciliation. Look specifically for Beers criteria medications, such as benzodiazepines or certain antihypertensives, that significantly increase the risk of syncope and fractures in the 65-plus population. Safety is the aging adult's highest priority. In this clinical scenario, we are navigating the complex intersection of finance and physiology for our patient Eleanor. For the older adult, financial insecurity is a significant psychosocial stressor that can manifest as physiological distress, affecting everything from blood pressure to sleep patterns. Medicare Part A serves as the foundation for inpatient coverage, covering semi-private rooms, meals, and hospital services. However, as nurses, we must understand the why behind the administration of this care. Why is it vital to reassure Eleanor early? Because an anxious patient is at higher risk for poor outcomes. When a patient is worried about how they will pay for their bed, they are less likely to focus on their incentive spirometry or early ambulation. We must act as advocates, coordinating with social work to ensure the patient feels secure in their coverage. Then we look at diagnosis-related groups, or DRGs. This is a prospective payment system that revolutionized healthcare reimbursement. Instead of paying for every single aspirin or gauze pad, Medicare pays a flat rate based on the patient's diagnosis. How does this change our nursing intervention? It creates a systemic push for efficiency. Because the payment is fixed, the hospital's goal is to treat the patient effectively within a specific time frame, known as the expected length of stay. NCLEX focus. You must remember that discharge planning does not begin on the day of discharge. In a DRG-driven system, discharge planning begins the moment of admission. As geriatric nurses, we are the ones who recognize that Eleanor may need a subacute rehab or home health long before the physician writes the order. We must document accurately and timely to justify the complexity of her care, as our notes provide the clinical evidence that supports the DRG assignment. Clinical Pearl. Use the teach-back method when explaining Medicare and DRGs to patients like Eleanor. Ask her, to make sure I explain this clearly, what is your understanding of how your hospital stay is being covered? This ensures she feels empowered and reduces the physiological impact of financial toxicity on her recovery. Always prioritize patient safety over discharge timelines. If a patient is not clinically stable, it is our professional duty to advocate for a DRG extension or an appeal against a premature discharge. Looking at the framework of Advance Directives, we are addressing the fundamental ethical principle of autonomy, even when the patient is physically or cognitively unable to voice their own choices. These documents are the clinical voice for the older adult. Why do we differentiate between these two specific documents? In geriatric nursing, we often encounter patients like Eleanor, whose health status may fluctuate due to chronic conditions or acute episodes. The durable power of attorney for healthcare is the WHO. It designates a healthcare proxy, a surrogate, to make decisions only when the patient loses decisional capacity. This is a legal transfer of authority. Without this, healthcare teams may face conflicting directions from various family members, leading to delays in care and significant moral distress for the nursing staff. On the right, the living will represents the what. This is an instructional document that outlines specific interventions. Does the patient want mechanical ventilation, artificial nutrition, cardiopulmonary resuscitation? Note the clinical safeguard mentioned. It generally only goes into effect when two physicians agree in writing that the patient is in a terminal state or permanently unconscious. How does this change our nursing intervention? When Eleanor is admitted, we are mandated by the Patient Self-Determination Act to ask if these documents exist. If they do, they must be part of the medical record immediately. NCLEX focus. Remember that as a nurse, you are an advocate, but you should not act as a legal witness for the signing of these documents while you are providing direct clinical care for the patient, as this can be seen as a conflict of interest. Clinical Pearl. Use the teach-back method with family members. Ask Eleanor's daughter, to ensure we are on the same page, what is your understanding of your role if your mother becomes unable to speak for herself? This confirms the surrogate understands that they must decide based on Eleanor's wishes, not their own. The primary focus here is the critical decision-making process involved in post-acute discharge planning for the geriatric patient, specifically Eleanor, who is recovering from a hip replacement. As nurses, we must distinguish between residential support and intensive rehabilitation. Why is this distinction vital for Eleanor's recovery? If we place her in a setting that cannot provide the rigorous physical therapy she requires, we risk permanent loss of mobility, increased fall risk, and a decline in her overall quality of life. Looking at the assisted living center, we see a social model of care. This environment is designed for older adults who are medically stable but require assistance with activities of daily living, like dressing or meal preparation. It offers privacy and community, but it lacks the 24-hour medical supervision and high-intensity therapy necessary for surgical recovery. Eleanor does not just need help, she needs rehabilitation. In contrast, the skilled care facility is a medical model. This is where Eleanor will receive daily physical therapy and occupational therapy. Following a major orthopedic surgery, the physiological goal is to restore the range of motion and weight-bearing capacity while monitoring for post-operative complications like deep vein thrombosis or surgical site infections. How does our nursing intervention change in this setting? We shift from custodial care to active restorative care, focusing on the interdisciplinary goal of returning her to her baseline level of function. For the NCLEX, you must understand the financial and regulatory aspects of care transitions. The nurse's note highlights a crucial piece of patient advocacy. Medicare Part A typically covers up to 100 days of skilled nursing care following a qualifying hospital stay. This knowledge allows us to alleviate the patient's anxiety regarding the cost of getting better, which is a significant psychosocial barrier to treatment adherence. Clinical Pearl. Always perform a teach-back with the family regarding the goals of a skilled care facility. Ensure they understand that the SNF is a temporary bridge designed to maximize independence, not a permanent placement. Clear communication during discharge planning is the #1 way to prevent hospital readmissions. Looking at this scenario involving Eleanor, we are forced to confront one of the most pervasive, yet often invisible, barriers to quality geriatric care: ageism. In our clinical practice, ageism isn't just a sociological term, it is a bias that can lead to diagnostic overshadowing and substandard nursing interventions. When we see a patient like Eleanor refusing to eat, the ageist assumption often defaults to labeling her as difficult, stubborn, or simply confused. But as geriatric nurses, we must ask, why is this behavior occurring? Is her refusal a clinical symptom of depression, or is it a calculated attempt to maintain a shred of autonomy in an environment that has stripped her of her home, her routine, and her privacy? In geriatric nursing theory, we recognize that the loss of control is a profound psychosocial stressor. When an older adult is admitted to an acute or long-term care facility, they often face a cascade of loss. If Eleanor cannot choose when she wakes up or who enters her room, the only thing she may still have power over is what she chooses to ingest. This isn't being difficult, it is a survival mechanism for the self. How does this change our nursing intervention? If we assume she is just old and stubborn, we might give up or resort to coercive feeding techniques. However, if we recognize this as a quest for self-direction, our intervention shifts towards empowerment. We might offer her choices. Would you prefer to eat by the window or at the table? Or would you like your tea now or in 20 minutes? These small concessions return power to the patient and directly combat the effects of institutionalization. NCLEX focus. When the boards ask about a patient refusing care, your first priority is always assessment before intervention. You must determine if the refusal is due to a physiological change, a cognitive change, or a psychosocial need for autonomy. Never assume a behavior is just a part of aging. Clinical Pearl. Always treat refusal of care as a form of communication. Before documenting a patient as non-compliant, use the teach-back method to ensure they understand the risks, and then investigate the why. Often, what looks like a clinical problem is actually a cry for dignity and control. Looking at this slide, we are challenged to move beyond Eleanor's clinical diagnoses, what we call the situation, and focus on Eleanor herself as a biological and psychosocial being. To provide evidence-based care, we must ask the critical why. Why is her body changing? As nurses, we don't just see a wrinkled hand or a slower gait. We see the manifestation of homeostenosis, which is the narrowing of the body's physiological reserve that occurs with age. In geriatric nursing, our practice is grounded in two major categories of aging theory: stochastic theories and non-stochastic theories. When we look at Eleanor, are we seeing the result of a predetermined genetic clock counting down cellular divisions, or are we seeing the cumulative wear and tear from free radical damage and environmental stressors over 8 decades? How we answer this determines our nursing interventions. If we follow the free radical theory, our care involves nutritional support and antioxidant-rich diets. If we look at disengagement theory, we might assess her psychosocial withdrawal differently than if we applied activity theory. For your NCLEX focus, remember this: Aging itself is not a disease. It is a universal, progressive process. The fundamental goal of the geriatric nurse is to differentiate between normal age-related changes and pathological processes. If we assume every change is just part of getting old, we will miss critical, treatable conditions like infections or metabolic imbalances that present atypically in the older adult. Clinical Pearl: always assess for the why before assuming a deficit. Before labeling an older adult as confused or non-compliant, look at the underlying theory of their physiological change. A sudden change in mental status is never a normal part of aging. It is a clinical emergency until proven otherwise.
Looking at the foundation of our clinical practice, we must recognize that caring for the older adult requires a unique synthesis of advanced physiological knowledge and profound psychosocial empathy. Why is this distinction so critical for the novice nurse? It is because the aging body does not always follow the textbook presentation of disease seen in younger adults. In this curriculum, the primary focus is understanding that geriatric nursing is not merely adult nursing with older patients. We are managing the complex interplay of decreased physiological reserve and multiple comorbidities. For instance, consider the presentation of infection. While a younger patient might present with a high fever, our geriatric patients often present with atypical symptoms, such as sudden onset confusion or a change in functional status. How does this change our nursing intervention? It means we must be vigilant in our baseline assessments to detect even the most subtle deviations. NCLEX focus. Board examinations frequently test your ability to prioritize safety and recognize the atypical signs of distress in the elderly. This text serves as a roadmap for identifying those high-risk scenarios, such as polypharmacy interactions or the early stages of delirium, before they escalate into a sentinel event. We are training you to look past the age and see the individual's specific physiological needs while maintaining their dignity through compassionate communication. Clinical Pearl: always use the teach-back method when providing discharge instructions or medication education to an older adult. Sensory changes such as high-frequency hearing loss or diminished visual acuity can lead to misunderstandings. Confirming understanding through verbal repetition reduces the risk of medication errors and readmission. The primary focus here is the integration of high-level clinical judgment into the complex world of geriatric nursing, translating the what of pathophysiology into the how of bedside care. When we look at nursing care plans and clinical situation boxes, we aren't just looking at lists of interventions. We are looking at the framework for managing patients with multiple comorbidities. Why is this assessment finding critical for the older adult? Because physiological changes, like reduced renal clearance or decreased thirst sensation, mean that a standard plan must be tailored to their unique baseline. We use these tools to move from theory to reality, ensuring we aren't just treating a diagnosis, but managing a human being with a lifetime of physiological history. Developing your clinical judgment through critical thinking boxes and NGN-style case studies is perhaps the most vital skill in your toolkit. In geriatrics, symptoms are often silent or atypical. How does a change in mental status reflect a potential infection in the absence of a fever? By working through these case studies, you learn to recognize subtle cues before they become a clinical crisis. You are learning to prioritize data, distinguishing between normal age-related changes and actual pathology. Finally, the NCLEX examination sections are designed to reinforce the high-stakes knowledge required for safe practice. As you review key points and questions, ask yourself, how does this intervention impact patient safety? In the geriatric population, the margin for error is slim. We focus on these review sections not just to pass a test, but to ensure that when you are the RN on the floor, you can advocate for your patient with confidence and evidence-based rationale. Clinical Pearl: when reviewing case studies, always apply the ABC and Maslow's hierarchy, but remember that in geriatrics, safety and fall prevention are often the highest priorities for maintaining a patient's functional independence. Looking at the landscape of aging presented here, we must recognize that geriatric nursing is no longer a subspecialty. It is the fundamental standard of care for the modern nurse. The complexity mentioned in this text refers to the unique physiological and psychosocial intersection we find in the older adult.
Where a younger patient might present with a textbook fever for an infection, why does our geriatric patient often present first with acute confusion or a sudden functional decline? This is the atypical presentation that demands the clinical expertise of the nurses you see before you. As we navigate this new era of healthcare, we must move beyond basic care to evidence-based practice. We use standardized tools like the SPICES assessment to catch subtle changes before they become catastrophic events. In the clinical setting, we aren't just looking at a diagnosis, we are managing the geriatric syndromes, those multifactorial conditions that don't fit into a single organ system, but significantly impact the quality of life. When we talk about being equipped with knowledge, we are specifically referring to understanding the difference between normal age-related changes and actual pathology. Is a decrease in bladder capacity a reason for total incontinence? No, it is a risk factor, but the cause is often an underlying treatable issue that a compassionate and knowledgeable nurse must investigate. From an NCLEX perspective, priority is always focused on safety and the prevention of complications. In a complex aging landscape, your priority is often fall prevention and medication safety. Because of decreased renal clearance and hepatic blood flow, the start low and go slow rule is your primary pharmacological safeguard. Clinical Pearl: always utilize the teach-back method when discussing discharge or new medications with the older adult. If they cannot explain the why and how of their care back to you in their own words, they are at a high risk for readmission. Assessment is the fundamental of everything we do in geriatrics. Never assume a new symptom is just because they are getting old. The primary focus here is the critical bridge between classroom theory and clinical application, the moment where reviewing your notes transforms into evidence-based practice at the bedside. In geriatric nursing, this transition is vital because our patients rarely present with a single isolated diagnosis. Instead, we are managing a complex interplay of chronic conditions, polypharmacy, and age-related physiological shifts. Why is this preclinical preparation so significant for patient outcomes? Because in the geriatric population, subtle changes in baseline status often signal major clinical deteriorations. If you haven't reviewed the patient's normal cognitive status or their specific gait patterns in your notes, you may miss the early indicators of a burgeoning urinary tract infection or a pharmacological adverse event. These silent presentations require a nurse who is not just present, but prepared. As a nurse educator, my priority is ensuring that your clinical judgment is rooted in the why behind the intervention. We are not just performing tasks, we are advocating for a population that is often marginalized in the healthcare system. This requires a deep understanding of the GSA clinical guidelines and the ability to apply them under pressure. NCLEX focus. When preparing for clinical rotations, prioritize assessments that address the highest risks for the older adult: falls, skin integrity, and medication toxicity. The boards will test your ability to prioritize these safety concerns over routine care tasks. Clinical Pearl. Always perform a head-to-toe baseline assessment at the very start of your shift. You cannot identify an acute change if you do not know the patient's baseline. Documenting stable is insufficient. You must document the specific functional and cognitive status of the older adult to ensure patient safety and continuity of care.